many of these patients with diabetes are actually paying out of pocket for testing strips. If you remember, I showed this device before. This actually requires strips, where you actually prick your finger, you get some blood, you put it on that strip, and you put it in the device. They'll pay like 20 to 30 bucks a month for those strips. We actually send these patients unlimited number of strips, right? And that's a huge attraction for them, which is why patients will sign up. We don't like to say things are free. We like to say that, hey, this is covered by your insurance. So in effect, there's zero cost to these patients. So something is zero cost and they can cancel anytime. There's no contract. You can imagine we have a lot of patients that will try this for a month, 3 months, 5 months. For us, we've got pretty low churn. Once patients come in, they don't leave usually, right? Because they see incredible value. They're getting supplies. They're getting access to providers. They see very high value, so they don't leave.
Interesting. So I mean, and that's on once they get into the flow, but it makes sense. So even for them, look, even $10 a month versus 50 bucks a month for these strips, that itself is value, exactly, right, that you guys are providing to them. But what about on the acquisition side? So how do you go out and find these patients? How do they get on board the platform?
Yeah, I know. So Bangladesh and the US are very different when we talk about health tech business models. Where I'd want to start is like, look at the payers. Look at who's paying for healthcare. In the US, there's multiple stakeholders paying for healthcare. So first of all, we have health insurance in the US. We have government insurance, and then we have private insurance. This is what we call payers, right? And then, so lots of startups, they have B2B business models where they're actually selling their service or their product to the payer. And the payer will turn around and provide that as a benefit to their beneficiaries, right? So everyone is incentivized, in that deal. A health insurance payer, like a Blue Cross Blue Shield, a United Health Group, their business model is make as much money as humanly possible, right? And the way that they do that is they charge premiums, monthly premiums, to patients. They're incentivized to keep patients as healthy as possible. The healthier a patient is, the less healthcare they're going to use, the more money an insurer can keep, right? They don't have to pay doctors. They don't have to pay hospitals. They want to keep that money. So payers are actually incentivized to buy services like ours that keep patients really healthy through virtual, through at home, right? Because that's a lot cheaper than, brick and mortar. So that's number one. The second thing is you have employers. In the US, we have employer-sponsored health insurance. So if I'm working at Target or Walmart or Amazon, right, which are some of the biggest employers in the US, they actually pay majority of my health insurance, right? Employers are also incentivized to keep me healthy, because if I have diabetes and I'm going to the hospital and I keep getting sick, I'm going to call out of work, right? That's decreased workforce productivity, So a lot of companies like us will actually sell into these employers. Many of these employers actually, it's what we call self-insured employers. They actually cover the cost of insurance for all their employees. They actually don't even contract with third-party insurance. So they have benefit managers that they work with. So a lot of companies will sell into really big employers, right? So payers and employers. And then lastly, you have providers actually will sell into hospitals and outpatient providers, right? So that's the B2B model, which we did last year. We have actually now shifted to a B2C model, which is actually very similar to what's happening in Bangladesh, but it's really more B2B2C, and I'll explain what that is. So for example, we talk and partner with senior centers, right? Because our market is elderly patients on Medicare, 65 and above. So when we built our map of where are our customers, where are our patients? First of all, we thought about, well, if we're at home, where are they living, right? So we looked at senior centers, elder centers, home care, assisted living. There's a huge market there, and they're looking for programs like this to keep their patients healthy and at home, right? So we actually partner with senior centers down in Florida, in Texas, Arizona, the Sun Belt states, where there's lots of retirees and elderly patients. And what I do, a part of my job is prospecting these senior centers, calling into them, cold calling, emailing, setting up webinars with their members. First of all, doing education around diabetes and wellness. And then at the very end, being like, oh, hey, by the way, we're at Perry Health. We have this service that's covered by Medicare at zero cost. Here's my information. If you're interested, reach out to me, right? But I actually have all the email addresses and the phone numbers, right, to begin with, right? So we actually acquire, through that B2B2C model, patients like that. We call that channel partnership. So we do senior centers. We also do patient advocacy groups. There are lots of patients that are part of diabetes advocacy groups online, right? Facebook groups, professional societies, and we will actually reach out to the admins of these groups. And again, we'll do these webinars, right? We do these informational, educational webinars, and we actually acquire many patients through that. Our most effective channel is of course digital. We do heavy Facebook advertising. The elderly love clicking on Facebook ads, and our cost of acquisition, or CAC, is really cheap. It's like $3 to $5, per lead, on Facebook. So, so we do digital and then we do channel. So we're able to get, like really thousands of patient leads, through these channels. And then, through kind of that conversion funnel, which we're now kind of working on, and hiring, we're now looking into like a call center model, right? And how do we kind of scale up that operation?
Yeah, I'm curious on that side too, right? So, I mean, I've heard of like customer success managers for B2B startups.
Yeah.
Do you have those for individuals, or how does that work, when it comes to, obviously this is the top of the funnel, but getting them, to go down towards the funnel and becoming actual users and recurring users?
Yeah. Customer experience, member experience, is really critical for a lot of companies at our stage. We're a seed stage company, like halfway to Series A, I would say. So growth is still critical. You can acquire a customer, you have to keep a customer, right? We're unique because we have lots of providers on the CX team nearby. So we actually have dietitians, we have nurses, we have myself. So we actually train. So not only do we do that CX ourselves, we actually will train the rest of the team on, again, what does patient empowerment look like? What is clinical language that you should be using? We don't treat these people like customers. We treat them like patients, right? So I think that's that mindset change that is really unique. And of course, we're incentivized with LTV, right? How do we keep these patients on our portal, on our program forever? It's not difficult when you listen to your patients and they say, hey, these are my 8 problems. So it's like, okay, great. Let's work with you on solving problems 1 and 2 first, right? So if you can take that approach with your patients, they're not going anywhere, on the CX side, if that makes sense.
I find it interesting, like the elements you're saying about kind of long-term LTV, low CAC, right?
Yeah.
And also combined with low churn, which is also like the holy grails of what you're looking for in any kind of a SaaS-based business, right?
Sure.
Including in consumer, which is hard. But on the other side is, when you talk about high touch, and a lot of customization, it does seem like there are scale challenges, right? Especially, yes. I'm just curious, how that relates then to your fundraising, right? Like the story that you have to tell. You mentioned you're at the seed round. I'm sure you're raising for further rounds. Like, how does that relate to like the fundraising story, I guess?
No, absolutely. We do run into load balancing issues. It's a real challenge, internally. I've mentioned on the CX side, the call center model that works for CX. For clinical care, though, right? It's a little bit different. How are you able to ensure that the same patient reaches the same provider all the time and not a different provider every time? As we're growing, that is something that we are struggling with. That is quite difficult. And again, the ways that you can deal with that are, again, tech. There's low acuity and then there's high acuity. we're looking into AI-based chatbots, right? Where our providers are not manually responding to every text, right? We're looking into especially triaging a lot of our patients, questions and needs kind of in this, pyramid of needs, right? When do our clinicians actually need to reach back out to you, physically over the phone? But yeah, so these are real problems. What I will say is that a lot of our peers are facing the same problems, but investors are actually looking to fund a lot of this because, virtual first or like hybrid care, in primary care, but specialty care, it is just open space right now. You can take X condition, Y demographic, right? Migraine for Black women, obesity for white men, fertility for any woman. That's now, an early stage company. But they're going through a lot of what we're going through, right? Like you've got this initial pool of patients, you're at a seed stage right now. How do we boost you up to an A, right? What does that scale look like? And again, it's got to be tech, right? I think you can do a lot of, like person to person high touch initially. But as you grow, you either have to, grow your care team to a point where now you've got like hundreds of providers, which I think for us is a potential, path. But again, like, some providers can be contracted. They don't have to be full time, right? I think there are workarounds. Again, you can use low levels or mid levels like NPs and PAs and EMTs, right? You don't have to have doctors, right? You can use nurses and pharmacists. Contracted pharmacy is something that we're actually looking into. They can actually do a lot of this, and many of them are just working in retail pharmacists. They're actually underutilized. And they're actually looking for opportunities like this. So I think when we look at other healthcare professionals and how they're being underutilized in their clinical positions, I think there's lots of opportunity there to bring them aboard.